introduce. So welcome everyone to the first of this academic year monthly seminar series at the Society of Functional Precision Medicine. My name is Tony Latai. I'm the president of the SFPM. Just a couple orders of business before we get started. First, I would just like to share to make sure you are all aware the results of our recent election. Hopefully you can all see what I'm sharing right now. I would also say if there's any board members on this call, you could, like I and Diana have done, put your camera on just so we can see your face and match a face to a name here in case people don't know you. We had some elections recently for both board and some executive positions with at the SFPM. I was not up for election this recent election. I'm still president. We have a new vice president, Karen Langenberg. Our treasurer, Jeff Tyner. Keith Ligon is our recording secretary. Alice Sarani is a board member at large. Diana Azam is a board member at large. Juan Montero is a board member at large. And we have two new positions that were created. These are both board members specifically assigned to someone working from the commercial sector, because we think that's a very important part of the mission of the SFPM. If we're going to really deliver this to patients, commercial interests have to be involved. And there's a variety of different regulatory and reimbursement issues, as well as other things that come up. And anyway, we're very happy to have Bruce Yeager and Christian Regenbrecht joining us as the board members from the commercial sector. Now, you should feel free to contact any of these people if you have ideas or initiatives for the SFPM. We really count on our membership to keep us apprised of any good new ideas you might have, whether it has to do with improving the membership experience, perhaps new initiatives we could be taking to spread the good word or to help companies out or help academics out, or whatever your ideas are, interactions that we could have. Please feel free to contact any of us and let us know your ideas, and we'll bring them forth to the board, and you may take part or even run a working group based on this. And that's how the work of the SFPM will be done. I also want to remind everyone that very shortly, just in a couple weeks, there will be a big meeting in Copenhagen, EHA SFPM Precision Medicine meeting. It will deal not only with hematologic, but also solid malignancies, and will bring together for the first time in a major meeting, both people from the genomic precision medicine world as people from the functional precision medicine world. And I think this is a kind of interaction that we need to increasingly have. I would very much encourage you, if you are, probably easier if you're European, but if you haven't registered for this meeting and have an interest, there are certainly slots open for you if you want. Please consider attending this meeting. It's a fun city, and I think it should be a truly excellent meeting. I think with that, I will unshare. I think the next order on the agenda for me is to introduce our two speakers, our two speakers for today. Our two speakers for today are Jared Barrett and Ken Dixon. Ken Dixon is a retired community cancer surgeon from Georgia. He trained at Emory and MD Anderson and practiced general surgical oncology. I think he has identified a very important facet of functional precision medicine, which is the storage, maintenance, and distribution of patient biospecimens. Like I like to say, all specimens, when they are resected from a patient, they're viable, they're living tissue. It is we who kill them when we fix them or freeze them improperly or whatever. So I think there's a lot of opportunity to change things and to better share our biospecimens. This is something that he has been very interested in. He founded a company, Specicare, to improve access to patient tissues. He'll tell you more about the details of what he has done this, and has collected a lot of specimens around the United States. He will be followed by Dr. Jared Barrett, who's an associate professor in the Department of Cell Biology and Physiology at Brigham Young University. He got a PhD at Duke University, has spent the past 10 years studying personalized medicine to treat sarcomas. He attended the inaugural SFPM meeting in 2019 in Atlanta, where he met Ken, who has also been a very, very early joiner of the SFPM. And they established an industry and academic collaboration that is trying to improve biospecimen management so we can have better personalized medicine for cancer patients. So I will stop there, and I will let Ken take over and correct anything I might have gotten wrong.
Well, Tony, I don't think you got anything wrong. I think you did it better than I can do it. But yeah, so Tony's right. I was a clinician until did my last operation in 2019. Became interested in the management of tumor biospecimens probably around 2008 or 2010, when I started hearing that tumors were unique and immune systems were unique, and realized the far distance between the research world and the clinical world. So Specicare is a company that is a biospecimen management company. Our goal is to provide options beyond typical standard of care, and that sort of mission was founded when I had a number of patients that were the age of my children that I lost after radiation, surgical, and medical oncology standard of care failed, and realized there's just a big gap between what I was reading in the research literature and what I saw in the clinical sphere. So our goal is to work through biospecimen management, and as Tony said, we're trying to make sure that the biospecimen journey doesn't end with formalin fixation and paraffin embedment. The idea of cryopreservation in the literature has been said to be financially and logistically impossible. We disagree with those conclusions. And we think that research and especially clinical care are being held back by multiple disciplines either require or better served by having biospecimens that are not formalin fixed, and cryopreservation is the alternative way to deal with that. So our menu of services includes accessing the individual cancer patient, providing the logistics, including the kit and the interactions with the clinical team and the pathologist to manage the biospecimen. We provide in-house cryopreservation, and we've got a biorepository that, while we haven't yet scaled, we think it provides the template for next steps. And at the present time, we've done some research that Jared will show you that shows that next generation sequencing is better done with cryopreserved specimens than SFPM, and we're working on that. So we do have a biorepository of over 300 unique patients with an emphasis on colorectal, urologic, and gynecologic tumors, but with a smattering of other tumors. We have multiple aliquots in the thousands of aliquots. Our consent does provide us access to medical records, and our venture was bolstered by the 21st Century Cures Act, which put teeth behind the idea that medical records have to be shared with the support of the individual patient. We now have data, whole genome sequencing data on 50 patients. We've done nearly 60 patients with an ex vivo chemotherapy panel through Quellos, and Jared's going to talk about that. We also have a limited optical genome mapping data on these patients. And before I say a word about Jared, I'll just say that, Francois Jacob and Monod and Lewaf did some remarkable work back in the 50s, but Jacob wrote some interesting books, and he has a quote that human life always involves a continuous dialogue between the possible and the actual. It is to this possible that we adjust our behaviors and actions. And I think those of us at this meeting here are thinking about the possible and trying to bring that into the actual. and Jared, I think your slide. So Jared did his PhD at Duke. I met him when I met him in 2019. He was he had already done his postdoc with um, at Huntsman Cancer Institute and was at Idaho State University. And he came to Brigham Young a couple of years ago. We've had an overlapping journey for the last several years where my clinical background and his research background has been an interesting ongoing dialogue. And I'm pleased to shift it over to Jared for the academic portion of this talk.
Yeah, thanks, Ken, so much, and Tony for those introductions, and just a pleasure to be here with everyone to talk about the biospecimen journey and how that impacts functional precision medicine. And I think the background is very sufficient to just kind of jump into what we're talking about. Here's some disclosures just that I feel is appropriate to share at this point in my relationships with Specicare at this time as an academic professor as well. So we're talking about the biospecimen management, and sometimes we just need to make sure everybody's on the same page of understanding what that means. And again, we're working with patients to extract out the tissue, whether that's blood or tumors, and put it in the best possible scenario, the best possible state, so that you can analyze and extract information from these tissues. And one big piece of this biospecimen management and extracting information and applying it is doing these ex vivo drug sensitivity assays, or functional precision medicine. And a lot of times what we see, though, and especially in academic and research settings, is that even if we have access to the biospecimen management, we don't always close the loop. It doesn't always come back to the benefit of the patient. And that's exactly where Specicare has its niche. It really wants to take information, not just to get samples out for the sake of getting samples and building a biorepository, but using that for the benefit of the individual patient. And that really speaks to what the mission of Specicare is listed here on this slide. That they're trying to manage that biospecimen for the patient so you can get the highest quality data that directs personalized care, and whether that's through genomics or precision medicine or the functional aspects of it. We just want to see that the patients are being taken care of to the best of the ability. And so when we hone in specifically on that phrase, the highest quality data that directs personalized care, there's a couple different approaches. And I'm glad that there's this new European conference that's coming up in Copenhagen that's bringing both parties together, because I think that there is a space where the genomics and functional precision medicine need to be interacting together to reach this goal of future medicine where there's a benefit for all. So currently, and Ken can attest to this, in the clinical community setting, we think of the current medicine as this kind of one treatment fits all. And when I say one treatment fits all for a given diagnostic, and we understand that there's lots of nuances within a given diagnostic, and that you can have patients that have that beneficial response, but many times, and sadly, there are patients that get no benefit from a given therapy. And then there are some that have no benefit, or the adverse events that are associated with that therapy. But through genomics, through functional precision medicine, we can start to bin and understand the molecular profiles that are associated with each individual patient, so that all the patients can benefit from a personalized medicine approach. And again, I feel like I'm preaching to the choir at a society like this. And we know that there are lots of benefits from the genomic precision medicine's standpoint. We've all heard the N of ones where, this patient had their genomics, their tumor profiled genomically, and they were able to make that precision match. And I'm no exception to that. I had a family friend that was diagnosed with stage 4 colon cancer, was given a prognosis of about 6 months to live. And he was wrapping up and getting ready to say a lot of his goodbyes. And during that process, I made the recommendation that he have his tumor sequenced. And being from Tennessee, he reached out to Vanderbilt, and they sequenced his tumor and found that it had a HER2 amplification. And that breathed a lot of life into the possibilities of how to treat his tumor, and actually went from a 6-month prognosis to a 5-year extension on his life, having the availability of a number of HER2 inhibitors. But when we look at the N of ones and we see those examples, the question is always, does that translate to population-based science? And we can see that the NIH is very interested in this and have done the NCI match trial to understand how precision medicine can be genomically guided. And this is a data that was taken from their website, most recently updated in December of 2023. And they state that they had 38 treatment arms, 1,100 different cancer centers involved in this match trial, with over 1,200 patients accrued and enrolled in the study. And what's interesting, as we look at this across the different studies, they set up their primary objectives to be this threshold of success of 16% for complete or partial response. It seems a bit low, but again, they're working with patients at this state that are their advanced stage cancers. And so just to have any kind of success would be something to get excited about. The secondary objective in this NCI match trial was to look at progression-free survival. And so they did a 6-month follow-up to see whether or not the patients had stable disease. And just to highlight 3 of the different treatment arms that existed within this study of the NCI match trial, I just want to highlight Arm I, Arm Q, and Arm W, which are therapies that are matching a given cancer or given mutation type. And so the first one, Arm I, was tezepelumab, treating patients that have a PIK3CA mutation. They had 65 patients in this study, and to see how many had complete or partial response, it was kind of sad that this one had 0. But the progression-free survival, 20% at 6 months, had that stable disease, despite being very advanced at the onset of treatment. Now, if we look at Arm Q, which is the adotrizumab, and the treatment of patients with the HER2 amplification, they had 37 patients enrolled in that study. They had a 5.6% response rate of either complete or partial response. So again, advanced stage, they're starting to see that this precision medicine can come about or lead to these type of responses. Half the patients, or almost half the patients, had progression-free survival at the 6-month mark. And then if you look over at Arm W, this is looking at an investigational drug, AZD4547, which treats FGFR mutations. And so the patients enrolled in this study, they had 48. They had 8% that were complete or partial responders, with a 38% progression-free survival at 6 months. And what's really interesting in this small graph down here at the bottom is when they broke down the type of mutations that existed within the FGFR patient population, the ones that responded the best was this dotted line up here, and these are all fusion mutations involving FGFR. And so even within the type of mutations, you can't just qualify and say, hey, everybody with the FGFR mutation can benefit from this drug, that there are differential responses based on the mutation types. And so with all that said, there leaves a lot left to be desired or wanting in terms of improvement and outcome. And they've transitioned and morphed their approach to look at earlier stage and combo match and immuno match type trials that are looking at how to get better benefits for these patients. But if you contrast what they've done with NCI match and the genomically guided precision medicine with what some of the studies have been found in functional precision medicine, I just want to highlight some of the studies that were done, first of all, by the EXALT trial, a group out of Munich, Germany, in which they were testing the response or the ability to match patients based on a 139 drug panel. And so they had 76 patients enrolled in the study. Again, they kind of set their threshold for success for complete or partial response, similar to the NCI match at 15%. And then a little different in their secondary objective of looking at progression-free survival, they decided to look at the ratio of their first treatment to the matched or functionally guided precision medicine therapy that helped them have better responses. And so they said if you had a response ratio or progression-free survival that was 30% better or 1.3, then that would deem a success threshold. And they did a follow-up of 24 months instead of that 6 month. And all this can be found, the data is published in Cancer Discovery back in 2022. But just to kind of highlight one of the pieces of data and the conclusions from this, they had the 56 patients that were on the FFPM arm, and then they had 20 patients on a control arm. What they found is that they had 20% of the patients on FPM treatment or guided therapy had exceptional response. So their progression-free survival ratio was 3 times better, or extended 3 times longer than when they were on their initial therapy. And so the progression, if you look at that broken down even more, they had 54% that reached that threshold of 1.3 progression-free survival ratio. The median was 3.4, and that hazard ratio was significant with a p-value. And you can see here the matched progression-free survival on their last therapy compared to their current therapy. And a lot of times when they had functional precision medicine to guide which therapy was chosen, those progression-free survivals definitely increased. And as Ken mentioned, we worked closely with another group here in the United States called Quellos, in which Pam Becker oversaw a lot of what was going on there. And again, they did functional precision medicine to see how feasible it was to match these therapies to patients. And their secondary objective was looking at the patient response. And so again, this was a trial that was focused on AMM. And so they had 170 drugs in their panel and applied this to 16 different patients. And what they found in this Quellos trial data, again, published in this paper, JCO of Precision Oncology, is that 13 of those patients, they received the personalized assay-guided therapies, and that 92% of them had stable disease. And so if you look specifically, you can see here how a panel of these drugs was applied to patient 10, and they were able to select out a couple of those drugs that gave good responses in the ex vivo drug test that eventually went on to give benefits back to the patient. And so with all this data kind of circulating, kind of this foundation that functional precision medicine is making some significant strides within the precision medicine, why are we not adopting more of it? And the question was, would more clinical oncologists adopt and use the data if they were given these data reports using functional precision medicine? And so exactly that's what Specicare set out to do with their own clinical trial registered through the NIH called the Pioneer Trial. And again, the primary objective of this was to just evaluate the use of FPM data by community oncologists to make these clinical treatment decisions. As we know, most of this FPM type stuff is happening at your comprehensive cancer centers with people who are at the forefront in the inner space of research and clinical applications. But are the people at the community setting where most patients are being treated, are they aware and able to internalize this type of data? And so we took 60 patients that received FPM assays from CLIA labs and that generated these clinical reports for the community oncologists. And what we found is sadly, 0% of the FPM data was being used by the community oncologists to make treatment decisions. And so it really made us, ask these important questions. Why is it not being used? Why, where is the most appropriate fit for FPM? Is it, just within these the comprehensive cancer centers, or can we extend it beyond to have a bigger impact at community centers? And what is like the clinical model for use? And as we've thought about this at Specicare and talking about the patient journey and how limited amounts of tumor you might get, and can it be used for functional precision medicine within a workflow, we kind of adopted this hierarchical workflow of biospecimen management. And so with this, you have a patient and their tumor will be taken out, extracted in the OR or potentially even a biopsy that was significantly large enough, and split up into the different processing types. Of course, we don't want to take anything away from the anatomical pathologist and their work that they need to do to provide the initial diagnostic. And so we would set aside some for FFP processing, but there's so much more that you can do with the tumor sample if you're properly managing and handling it in a cryopreserved fashion. And so the way that we see it is that kind of the next bin, or as you track down these steps, kind of looking at as a water flow plot, as there's tumor specimen left over, it falls into the next bucket or bin. And then as that fills up and they use it, then the leftover can be, used at subsequent steps. And so we kind of see the molecular pathology, the NGS, the RNA sequencing, proteomics, methylation sequencing as kind of being that next step in the hierarchical workflow. Following that is where functional precision medicine has its place, we feel, within this biospecimen hierarchical workflow. Following the functional precision medicine would be a way of characterizing or isolating T cells and other immune cells to generate or personalized immunotherapies. And then lastly, we see that there is still benefit if all these other options are exhausted for the patient, if there's remnant tissue, to cryostore that for future applications that have yet to be developed. And so what are some of those benefits of cryopreservation? As you probably already know, they're very viable. You can have long storage. And there's also a lot of versatility associated with this type of tissue management or storage. It can be applied in lots of different settings where FFP tissue really has its limitations and what you can do with it downstream if you put it all into formalin and fix it. And so we actually did a head-to-head comparison looking at the benefits of cryopreservation compared to FFP. And we looked at it just in the simplest terms of DNA quality and quantity. And we saw just in a summary here that you get a lot more DNA out of cryopreserved tissue. And so if you're putting more tissue into that space and you can extract more DNA, you can actually do a lot more tests and hopefully have subsequent tissue or leftover remnant tissue for the downstream applications such as functional precision medicine and personalized immunotherapy development. We see that not only is the yield significantly better and different, but the DNA quality, as anybody who's in an academic lab and does research with DNA understands that the FFP has significant detrimental effects on the length as well as the quality. And so the way we kind of reimagined or are thinking about, if we want to work more in the space of biospecimen management with smaller tissues, such as an 18-gauge needle, you might be getting just 5 to 20 milligrams of tissue from that 18-gauge needle. Can you get by, and this is just us posturing that, can you get by with just 1 to 5 milligrams being sent off to the pathologist for that FFP processing and histological analysis or diagnostic? Could you use, because it's because it's cryopreserved, could you get by with 1 to 5 milligrams of that tissue to do a lot of the molecular characterization, such as next-gen sequencing, whole genome sequencing, RNA sequencing, even some of the proteomics? They can get down to single cell nowadays for these proteomics. And then that would leave over 10 to 18 milligrams of tissue for ex vivo drug testing or functional precision medicine testing. And so that's one of the questions that we want to pose to this society of functional precision medicine. Is there a way to shrink and get down to assays that use less tissue so that the benefits of functional precision medicine can be applied in these core needle biopsy space where you're working with very small amounts? And we think that there is a space if you combine both the genomics and the functional precision medicine together. So if you're using genomics guided functional precision medicine, you can shrink those panels of drugs that you're applying in order to get those benefits of saying, hey, this is the drugs that we think will have the best optimal or the best chance of benefiting the patient. So again, you have the patient, the tumors being split up, you have the clinical sequencing that leads to candidate therapy selection, the application in ex vivo drug panel testing. And what's interesting is that you can use all this information from the functional precision medicine as a feedback to guide and come up with biomarkers and genetic tests that help refine the type of panels of drugs that are being used in the functional precision medicine space. And so the other aspect within functional precision medicine that we think that there's a great benefit is not just working and redirecting FDA-approved drugs for the benefit of the patient, but working in the investigational new drug space and doing what's called co-clinical trials. And so this can become a tool in patient identification. If you're taking those patient samples that are cryopreserved, doing functional precision medicine, before you even recruit them, you have a panel of investigational drugs for a biopharma company, and you can say, hey, this drug works really well for this patient. You should consider enrolling them in your clinical trial. And so again, you have this panel of investigational drugs, not just FDA-approved ones that can really target and help identify those patients that can benefit. Now, the other thing that we want to maybe bring up as a discussion point is this a need for autologous cold culture systems to really expand the services and testing these investigational immunotherapies. And if you look currently in clinicaltrials.gov, one of the really exciting spaces that's exploding in cancer pharmacology are these antibody drug conjugates. And if there's a way to include those into the panel design, I think there's a great benefit for expanding and testing and finding patients that will benefit for those different and novel type therapies. And so coming back to the point that I made about the versatility of cryopreserved tissue, one of the things that that we kind of see is that cryopreserved checks the box on all these different sample or characterizations that you can do to analyze the patient's tumor. And so if you look down here on the left side column, you can see the different applications of molecular characterization or even therapeutic developments that can take place with the different types of tissue. And then up here across the different columns, we have the different tissue types. So whether that's FFPE, the flash frozen, fresh, or cryopreserved. And so again, you can see just how limited FFPE is in the types of applications that you can get in the molecular characterization, molecular pathology field. Flash frozen has its benefits with certain characterizations, but we know that it has some impact on viability if it's not done correctly. Fresh obviously is great, but limits the ability to have this way to transport and store it for long term and maybe share that tissue with other people. And so we feel that cryopreserved, again, just has this high accuracy and high feasibility across all these different applications in the molecular space of characterizing these tumors and getting information that can benefit the patient. And so this is meant to be hopefully a little bit short in order to allow for enough time for discussion. We'd love to see some of the questions that we've posed be brought up and kind of having a dialogue, not just between Ken and I and with you guys at the Society of Functional Precision Medicine, but also amongst yourselves to kind of say, what is the benefit? How can we, is there a space in which genomics and functional precision medicine can intersect to help decrease the amount of size so that we can work with smaller amounts of tissue to make these functional precision medicines more broadly applicable? Also, where is that gap and how can we close the gap where patients are going to their community cancer centers and the community oncologist doesn't even know how to use a functional precision medicine report to guide therapeutic decisions? How can we make that translation in the community cancer centers a little bit better? And so just to kind of share some of the conclusions that we've talked about is that cryopreserved tissue really maximizes the number of characterizations that can be performed on a tissue. It shows just so much more versatility. the functional precision medicine assays can be guided by genomics. And by doing that, you can decrease the size of the drug panels. That results from the functional precision medicine assay can be used to find predictive genomic biomarkers. So there's that feedback, and that co-clinical trials can be used to recruit patients in going into the innovative therapeutic space, or these investigational drugs that are coming down the pipeline. And so I just need to give a quick acknowledgement to the team at Specicare, the individuals that do such a great job over there of managing the patient tumor samples. Within my lab here at Brigham Young University, we have a number of students that are making an impact and doing a lot of the characterizations that are showing those differences. And then we have a number of external collaborators that help us with further characterizing and doing these tests, such as the BYU DNA sequencing core, Enocras, as well as Quellos. And so with that, hopefully that leaves ample time for questions and discussions. And I guess I'll turn it back over to Tony to kind of moderate that. So.
Great. Yeah. Thanks a lot, Jared. I think there are several questions. I'll start with one. I'll use my prerogative to ask first question. I think you're very much preaching to the choir. Probably most people on this call will agree about the use of viably frozen specimens, how useful that is. Could you be a little more specific about the role of Specicare? What is its mission and business model? Where does it fit in? Does it have as clients individual patients or FPM companies, or is it planning on doing FPM itself? I'm still not clear on exactly what Specicare's business model is, what its mission and business model are.
Yeah, I'll take the first stab at that, and if I don't get it completely, Ken will correct me. But the mission of Specicare is to be able to access or help the individual patient kind of navigate what they can do to optimize or maximize the benefits of characterization for their individual circumstance. And so whether that's genomic sequencing that helps guide therapeutic decisions, or functional precision medicine, we are kind of the company that goes out and logistically handles the biospecimen, getting it out of the operating room, making sure it gets handled properly, going into cryopreservation. And at that point, we say that the patient is in the driver's seat, and they get to kind of decide they're the owners of their tissue. And so they can decide, do I want genomics? Do I want functional precision medicine? And we have collaborators that we reach out to and kind of provide this kind of a la carte service of, here are all the things that you could do with your tumor. What do you want to take advantage of? And we try and provide layman term science to help guide those decisions so that the patient can make an informed decision. But in the end, we want them to get the benefit that comes back to them.
Okay, so in other words, your client is the individual patient.
It is.
Okay, and then you would sort of act as something of a broker, or just sort of identify what solutions might work with them once you've acquired their tissue.
That is correct.
Okay, that's useful.
Tony, let me add, that change is difficult, and we think, and let me say that also Scott Cooper, who's our COO, is on the line. He has the ability to be a little more succinct than I do, but we are looking. We think that the pathologist is the steward of the biospecimen, but that is not just a 100% thing. That the patient should have the ability to interact, particularly when the biospecimen journey is so truncated most of the time. So we're interested in approaching patients directly in discussions with medical oncologists as well as with pathologists. So we welcome B2B interactions, but are primarily targeting consumers at this time.
Okay, thank you. I see Bruce Yeager has a couple questions. Bruce, do you want to put these questions yourself?
Sure, just had to get on mute. The Pioneer trial. When did you guys run that?
When,
Yes, when did you run it?
starting around 2018.
Okay, so a couple years ago. And,
Yeah.
and it's more coming off of my limited experience with this, but it seems like we have a well-worn path for people to outsource genomic testing, starting with dead specimens from that perspective. But there's not a well-worn path for obtaining live specimens. That to me is going to be the challenge, and to the extent with which we're able to try to operationalize this will make life easier for everybody involved in this going forward.
I certainly agree. I think there are multiple clinical applications, many of which are require living specimens, and essentially all of which, other than histopathology, are better with cryopreserved than FFPE. So the functional precision medicine space is one of these subsets, and I think as we solve the biospecimen management collection and preservation issue, that it directly benefits functional precision medicine.
Yeah, Ken and Jared, this is Keith Ligon. Just on the point of Specicare has been in a lot of contact with patients and providers for a long time. Have you seen much change in the awareness or increasing accommodation for live testing and the pathologist or institutions that you've worked with over time, or what do you see for a trajectory of that right now?
I think I'll let Jared and Scott weigh in too, but unfortunately, my view is that no, we have not seen an upward trajectory yet, other than I would say that over the last few years, now I see the medical oncology space starting to embrace genomics, and that's been slow coming, but I think things are starting to change in one of the clinical applications, and hopefully others will follow.
I'd like to, one of you brought this up, and I think this is something I think the board has recognized, is that sort of like, if only there was some gathering of medical oncologists and, nationally in the United States. Well, of course it exists. That's ASCO. And I would say that we have appreciated that our links and our presence at ASCO are definitely not what they should be. We're a small organization. We continue to learn. So one of the things that we want to do is make better connections with ASCO, JCO, and that is really a very important target audience for the SFPM. If you would like to, and Keith, maybe you have something you want to say about that, but I would say just to this audience, if you want to participate in that, or you have some ideas about that, please get in touch with us, because we feel that that is going to be an important point of contact. We need to basically have them be aware of who the SFPM is. Keith, do you have anything you want to say about that?
I would totally agree. And then I think the thing that we need to do is expand it to other clinical groups, like anybody in the workflow. IR is a key collaborator, I know, for many of the companies on the call, and obtaining specimens, and those are different clinicians. So I think these are the things where we do really benefit from the team effort of the group and people joining the work groups to address that. Yeah, it requires a long, protracted pressure and communication and just sort of evangelism for it.
From I imagine Riga, Latvia, and the Baltic states, Ineza Kakstina-Zerva asks, who is paying for the cryopreservation and storage of tissues? I guess she means in the context of Specicare.
This is a patient pay model at the present time, not insurance covered. And obviously that's one of the obstacles, but I would say that the cost is just as the cost of technologies such as genomics coming down, the cost of cryopreservation at scale, of collection and cryopreservation at scale is doable.
Mike Perricone, sorry, someone wanted to have a question. They wanted to say that. I don't know. Mike Perricone asked an interesting question. I think, what is the actual process you use? I'm curious about that too. To what extent did you optimize this, and to what extent are your protocols publicly available for how you store fresh tissue at Specicare?
It's basically a adoption of the research protocol. We transport it in hypothermosol. We cut it up into 50 to 100 milligram aliquots, 2 by 2, 2 by 3 millimeters. Then place them in a cryovial, which is placed in cryo store. Put in a Mr. Frosty into a -80 freezer, and then it's transferred over to liquid nitrogen. The protocol is essentially the same one as that's done at UC San Diego. I forget the name of the authors there, but I'd be glad to interact with any of the membership about that.
I will say that, like, I am not convinced that for FPM applications that we as a field or individuals have really and I include my own laboratory, have really been able to spend the time that is really necessary to know that we are dealing with optimal conditions for developing an FPM tool. I'll just, as one example, we have found numerous times people have cryopreservation in PDX models. There's cryopreservation models, that protocols that people use all the time, and they work great. They work great for PDX models where people can, indefinitely propagate a PDX model using these cryopreserved tissues. But if you look at from an FPM perspective, when you take those same tissues and try to study them, you'll find that the viability is generally less than 10% using those same protocols, and that renders it way too noisy for an FPM application. So I think we have to just realize that a lot of the cryopreservation technologies were designed for other things, not for us.
I have two responses to that, Tony. First, I would agree that the field of live tissue science or biospecimen management is in its infancy. The second thing I would say is, when we look at what we did with Quellos, we were able to do ex vivo drug panel testing on 75% of patients. We failed on a quarter, but that did include first and second tries. So we were somewhere between 50 and 75% with the first try, and then we had additional vials that we would send Tim Martins at Quellos to get us up to that 75% number.
Okay, and it's useful for you to sort of acknowledge that you're not at 100%. None of us can be. In that context, I just want to go back to the match trial. Jared was too kind and left this out. But I think something worth recognizing is that probably fewer than 1 in 6 or 1 in 7 patients even made it to a treatment arm after having their genome done. So any statistics you see are not truly an intention to treat approach, because they sequenced about 7,000 patient samples, and 6,000 or 7,000, and like 750 of those actually registered a mutation that actually got them to an arm. And it was only after they reached this arm that we saw these sometimes very depressing and very limited response rates, for an overall intention to treat response rate on the order of like 1.5%, which is, I think, far below what people might have expected. I just want to point out that that's often left out of an analysis of the match trial, like pretty significant. I'm going to go on with some other questions from Dr. Shi. She's interested in the concept of blood-derived samples. She's saying that we can grow circulating tumor cells and organoids for drug screening. What I know about the field is that works for certain tumors, like small cell lung cancer, pretty well. Can be a major challenge for others due to the paucity of cells. What experience does Specicare have with this? And Dr. Shi might want to comment too.
We do not have any experience with it. I would be interested in her comments.
Yes, hi, this is SJ. Yeah, not only the CTC, but also I think that to compare the
Oh, Dr.
the
Shi,
cfDNA, I think will be interesting. It's the cfDNA and then we treat it. Yes, we can grow the. Yeah. Sorry.
you froze up briefly, Dr. Shi. Maybe you could repeat your comments.
Oh, okay. I say the derived material also including the cfDNA. I don't know if that's worth comparison or not. But in terms of your question about how that worked, we can work on most of the solid tumors, not only lung. There are other tumors we can work on. The only thing we could not work on is the heme tumor. Yeah, I can reach out to Dr. Dixon and Barrett to do further discussion. Thanks.
There's a request, Jared, that maybe you could amplify a little bit on the feedback loop between FPM and how that might provide genomic insight. And indeed, I'm curious about that too, because I know like in the EXALT trial, one of the main points is that a lot of the effective therapies chosen had no genetic biomarker that would have been informative for those.
Yeah, but as we expand the scope of doing whole genome sequencing and hopefully finding patterns, I mean, again, it's very speculative, but trying to say, hey, that there are patient responders to these drugs, and so what's unique about those patients' genomic profiles that could, and it's going to be most likely a multi-omics approach and not just simply looking at the DNA, but taking into account methylation status and RNA expression, as well as the gene mutational status, that will help us, close that loop back of saying, okay, we can have a better idea of how to predict who's going to respond to these drugs based off their profile. And it's not going to be simply DNA sequencing that's going to be able to suffice and give us that complete picture.
Thanks. There's an interesting question here from Colin Paul, basically asking, have you given any thoughts on your freezing techniques versus working to extend viable transport time at 4 degrees C? That's an alternative approach. Have you guys looked into that at all?
We have. Yep. We're exploring that to see just how we can optimize and extend that so we can just keep things as viable without going through the freezing process. But again, there are also some benefits of cryostoring and preserving the tissue for future applications that just aren't available at this time.
Along those lines, Impromed, someone from Impromed is asking. Impromed, you might know, is an FPM company that has an interesting approach of working not only in the animal community, but also in the non-human, but also in the human and animal community. Have you ever done any comparisons in your ex vivo testing results between fresh and cryopreserved for the exact same sample to see what the correspondence is?
We have not.
Hi, Tony. This is someone from Implement. Sorry for the video out. Yes, we do have. Basically, we are using fresh samples from animals and also from human. Definitely it works a lot better. And we have our specialized media that's not designed for the cryo storage, but to keep the cells metabolic activity for at least like a week or two. But we actually use that for tested our cryopreservation, and then we got a preliminary results that it is superior than the conventional method that Gerard and then Ken described. So we will definitely have some of the data, more data later, and then we'll be happy to share that data later. But so far we only get the preliminary result, which is exciting, but I cannot promise that it will work.
We're interested in that. My response to that is that it's difficult enough to preserve the moment in time beyond that initial event. And if we're having to do everything have all the connections made at this time to be able to do functional precision medicine on these specimens. I think that's a significant obstacle.
Yeah, I completely agree with you, Ken. And definitely I want to talk to you after this. I will email you.
Sounds great.
Well, is Imprimed's media, you say they have a special media, is that publicly available for others to test?
Not for now, but many investors actually ask that exactly same question, that are you going to sell this media to others? But so far, we're just trying to keep that as our proprietary media, and then expand our database in-house.
Okay, should you ever change your mind, the SFPM would be very happy to be an organ of communication of your recipes to the community at large. If that
You will be the first person to receive that message, Tony.
Great. We are reaching the top of the hour. I had a comment I wanted to make before I left, which is that hopefully you all enjoyed today's presentation as much as I did. I think many on this call have much that you could offer us. If you feel that you have a presentation you would like to share with this community during a seminar series, feel free to contact us. You can go to our website and contact us that way, or you can contact any of the board members, and we can arrange for you to give one of these seminars. We are filling up pretty rapidly our seminar series for 2025. So if you want to take part, now is the time to let us know. I think it remains just to thank Ken and Jared for a very interesting presentation. I think you've taken a different approach to a lot of us in really focusing on the tissue first, and I think that is the very important facet of functional precision medicine. I look forward to see those of you who are attending in Copenhagen. I know I'm looking at several who will be there. And please come up and introduce yourself if we've not met in person. We'd be very glad to meet you. So with that, I'll say goodbye and see you in October.